live.
Oh, it's going up fast now.
Yeah, because I just hit it a middle.
Oh, there's Lisa. There's Lisa Steele from Hi.
We're well over 40.
Oh, that's nice. I don't know her, but nice to meet you.
Yeah, that's lovely, Lisa.
I've even got a relative from Spain who's joined. Oh, seriously, I've just seen their name on here.
Good to start.
Okay. Well, good evening, ladies and gentlemen, and welcome to this session in the Edgware United Synagogue Adult Education Programme entitled BRCA Living with a Cancer Gene Mutation. BRCA is an abbreviation of breast cancer gene. You may have seen an article in the Jewish press 4 weeks ago, a headline, NHS to launch new programme of BRCA genetic testing for Jewish community. Up to 1 in 40 Jews carry the genetic mutations, which can lead to certain cancers, compared to 1 in 400 in the general population. The fact is that not all men and women are created equal. As far as the Jewish community is concerned, there are some genetic diseases that are more common among people of Jewish descent, particularly Ashkenazim, than in the general population. Most of us are familiar with Tay-Sachs, but there are many other diseases that we need to make our community aware of. Among these are breast cancer and ovarian cancer, and our speaker tonight, Sara Balabanoff, a member of our Edgware US community, who is the head of user research NHS England, will talk about her experiences of living with a BRCA gene mutation. Katrina Sarig, who is the project director of the Jewish Hereditary Cancer Review, will act as chair for this event. After the presentation, there will be a Q&A, and you can either type your question in the Zoom chat or raise your virtual hand, or if you are viewing on YouTube, you can type a comment. So over to you, Sarah and Katrina.
So thank you very much, Edgware United Synagogue, for giving Sara and myself the opportunity to raise awareness about BRCA. As Spencer mentioned, I'm the director of the Jewish Hereditary Cancer Review, a project based at Queen Mary's University of London researching BRCA awareness and testing in the UK Jewish population. I've just seen that we have both Michelle Ferris, who's an advisor on the study, and Professor r.manchanda also joined. So they may be able to help should there be any technical or particular medical questions later on. So in March of this year, I had the pleasure of hearing Sara talk about her experience living with BRCA to work colleagues. And the focus of this event this evening is very much listening to that experience and hearing Sara talk. But just as an introduction, although Spencer's just sort of covered a lot of the stuff that I was going to say anyway as an introduction, but just to consolidate the introduction about BRCA that Spencer's just given us, I'm just going to literally take 2 or 3 minutes to give a bit of a background to what we understand by BRCA. So BRCA does actually stand for breast cancer. It refers to 2 genes that we have named BRCA1 and BRCA2 that are among about 20 to 30,000 genes that we all have as humans. So we all have BRCA genes, and BRCA1 and BRCA2, these are tumor suppressor genes that when working properly and functioning normally, their role is to repair cell damage and prevent uncontrolled cell growth. When there are changes, oh, sorry, can we have the next slide to help manage this, if that could be pushed on? Sorry, I don't have control of the slides. Because someone pass this?
Elliot, can you go to
Elliot, put the next slide on. I'm pressing with my cursor, but I have no control over this, so it's remote.
Elliot.
Wonderful. No, that's done. That's fantastic. Okay, so when there are changes, or more commonly known as mutations in the BRCA genes, they reduce the gene's ability to work properly, and this leads to us being more susceptible to certain types of cancer. Hereditary breast cancer is the one that is most associated with the BRCA genes, and actually BRCA mutations account for the most cases of hereditary breast cancer. However, there are other genes associated, or gene mutations associated with hereditary breast cancer. And furthermore, BRCA mutations also are known to increase the risk for other hereditary cancers, including ovarian cancer, prostate cancer, pancreatic cancer, and melanoma. So someone who has a BRCA mutation is often referred to as a BRCA carrier. And BRCA carriers, by having the mutation, it doesn't mean that they will automatically get cancer. Not everyone with a BRCA mutation gets cancer. But what it does mean is that they all have an increased risk of getting some of these hereditary cancers relative to people that don't have these BRCA mutations. So that increased risk that BRCA mutations have varies across what type of cancer they may have, and the two BRCA genes, the risk varies across those. So I'm not going to go into that detail now, but if we could go to the next slide, we can have a look at how BRCA carriers are actually passed on from parents to child. So BRCA mutations are passed on in what is called an autosomal dominant way. So we all actually have two copies of every gene. So we have two copies of the BRCA1 gene and BRCA2 gene. And when with reproduction, we pass on, the mother passes on one copy and the father passes on another copy. And so the child inherits two copies. Where you have a couple where one of the partners is a BRCA carrier, so it has one of their BRCA genes with a fault or mutation, then there will be a 50% chance of their child inheriting that BRCA mutation. So that is even when the other partner in the couple does not have a BRCA mutation. There is only one BRCA mutation, one partner carrier needed for there to be a 50% chance of the children, and that's with every conception. Each child will have a 50% chance of inheriting a faulty BRCA gene and a 50% chance of inheriting a normal BRCA gene. And this is the same whether the BRCA carrier parent is male or female. So BRCA mutations are equally passed on through mother and through father, and that's something that's often misunderstood. So the final thing that I'm going to say before passing on to Sara is just, if we can go to the next slide. Again, something that Spencer mentioned, actually more recent research has found that in the general population, the BRCA carriers occur about 1 in 200 to 300 people, whereas within the Ashkenazi Jewish population, 1 in 40 people are BRCA carriers. So that amounts to 2.5% of the Ashkenazi Jewish population, and an increased risk of approximately 5-fold of being a BRCA carrier if you have Ashkenazi Jewish heritage relative to others in the general population. It's important to note that there is also within certain non-Ashkenazi Jewish populations an increased risk as well, and that shouldn't be forgotten when looking at the whole BRCA picture. So 1 in 40 of the Ashkenazi Jewish population are BRCA carriers, and Sara is one of those 1 in 40. And I'd like to hand over now to Sara to share with her personal experience of what it means to her to find out that she was a BRCA carrier and how she has managed that risk. So Sara, over to you.
So thank you to Edgware United for giving me this opportunity to speak about my experience of having a BRCA gene mutation. And thank you to Katrina for doing all the scientific stuff. That was a great intro. And also thank you to everyone who's joined to listen. I appreciate the support. So in 2016, I was diagnosed as having the BRCA or BRCA2 gene mutation. And since then, I've undergone 2 sets of major preventative surgery in order to reduce my previously very high risk of getting breast and ovarian cancers. However, my personal story really began in 1996, when my maternal grandmother was diagnosed with breast cancer at the age of 62. This was around the time that testing for BRCA gene mutations first began in America and Australia, but was not yet routinely undertaken in the UK. So my grandma was not tested. Thankfully, my grandma was successfully treated for her breast cancer by a mastectomy, that is removal of the breast, and radiotherapy. Then in 2010, when my grandma was 70 years old, unfortunately, she was diagnosed with cancer for a second time, this time with a type of pancreatic cancer. Happily, she was successfully treated for this by undergoing the Whipple procedure, which is a complex operation to remove the head of the pancreas, the first part of the small intestine, the gallbladder, and the bile duct. My grandma was lucky that her pancreatic cancer was caught early enough for surgery to be effective, as less than 10% of people diagnosed with pancreatic cancer survive for 5 years or more following diagnosis. Then, in 2010, my mother, who was then 56, was diagnosed with breast cancer. My mum was treated first by a lumpectomy, that is surgery to remove cancer from a breast without removing the entire breast. And then, when unfortunately that didn't suffice, a mastectomy and breast reconstruction. After my mum's treatment was complete, and having discussed it with her GP, she then went for genetic counselling, which in those days was a mandatory precursor for getting tested for a BRCA gene mutation. The genetic test itself is essentially a blood test, and unfortunately, my mum's came back that she was positive for the BRCA2 gene mutation, although her brother, my uncle, is not. Following her BRCA2 carrier diagnosis, my mum opted to have her other breasts removed and reconstructed, as well as her ovaries removed as preventative measures. My mum's BRCA2 carrier status meant that my 2 siblings and I each had a 50% chance of carrying the same gene mutation. In addition, my brother has 2 children of his own, so if he is a carrier, then they will also each have a 50% chance of having it. However, neither my siblings nor I immediately opted to be tested. In the interim, my sister and I began undergoing annual MRI scans of our breasts because of our high risk of breast cancer. An MRI of your breasts is really unpleasant and involves lying face down in an MRI scanner whilst encasing your breasts in 2 separate cages and having dye injected into you. A radiographer once commented to me that breast MRIs are the worst, and I don't think he was wrong. In 2016, my breast MRI scan was returned with a query, and I had a biopsy to investigate further. Whilst thankfully the biopsy was negative for cancer, it scared me enough that I decided to go for genetic counselling in advance of a BRCA gene mutation test. My BRCA2 gene mutation test came back positive, which at the time I think was more devastating for my parents than me. Psychologically, I have taken all of this surprisingly well. I think because I considered that I've been through much worse separately with another unrelated and misdiagnosed health matter. Certainly, there were not times prior to either of my major preventative surgeries that I was completely devastated, nor did I travel to them in tears or similar, as I have heard happens to many people. A date was set in February 2017 for my double mastectomy and reconstruction. However, unfortunately, on the day and at the last minute, once I had already been marked and gowned up for surgery, the operation was cancelled as the anaesthetist was concerned that I had not been told a month prior to stop taking the contraceptive pill. I fully empathise with the Country File presenter Julia Bradbury's recent comments about the moment she looked down at the thick felt tip markings on her breasts, which had been made for the surgeon carrying out her mastectomy when she had breast cancer, which they were like something you see in the butchers. I felt like a piece of meat. This description helps to explain why it was particularly disappointing and distressing that I had unnecessarily been marked up with thick black felt tip pen, only for the operation to be cancelled. My 12-hour surgery was rescheduled for the following month and finally took place on the 25th of March 2017, which is now over 5 years ago. Unfortunately, there were some complications in theatre, particularly with my left breast, which has never fully recovered. The reconstruction type that I had is called a breast deep inferior epigastric perforator, or DEP flap reconstruction, which means that my breasts were rebuilt using skin and fat from my abdomen, so I have avoided having implants or silicone put inside me. It is difficult to describe to someone who has not experienced it what it is like to go through major surgery of the magnitude of a double mastectomy and reconstruction. To give you an idea, my plastic surgeon compared it to open heart surgery or being run over by a bus. When I came round from the operation, I was on 4 drains, a catheter, and had several cannulas and intravenous drips coming out of me. I was hardly able to sit up and was most certainly not able to get out of bed or do simple tasks like clean my teeth or brush my hair by myself. Indeed, to start with, I was given fluids from something that resembled a spout cup. I was laid in bed in a hospital gown for several days, and it makes me laugh now to remember that at the time, someone messaged me to see if I would like to have a manicure. As I said, I wasn't even able to clean my own teeth, never mind have a manicure. Another odd comparison that someone made to me at the time was that being diagnosed with a BRCA gene mutation was like not getting your first choice of school place for your children. As I don't have children, I haven't experienced this firsthand. However, if I'm honest, I don't feel that it was a particularly good comparison. On reflection, I think people can sometimes find it hard to know what to say, so can end up saying silly, inappropriate, or even offensive things. When I was first diagnosed, a good friend said to me that she didn't really know much about BRCA, so could I explain it to her? I really appreciated that and thought that was a good way to approach talking to me about it, given that she didn't know much but wanted to learn more in order to understand and be supportive. Once I'd come round from my major surgery, I was initially put on tramadol, which is a strong, addictive and prescription-only painkiller. But as it gave me hallucinations, I was quickly taken off that and put on paracetamol instead. All I can say is it's just as well that I apparently have a high threshold to pay. A couple of days later, when the ward matron insisted that I try to get out of bed for the first time, I collapsed and consequently was given a blood transfusion. After a further few days, during which I successfully navigated moving from my hospital bed to a chair next to it, my catheter was removed and I was able to go to the toilet in the conventional way and by myself, which at the time felt amazing. I was also able to start using dry shampoo, which became something of a godsend. A nurse also fitted me with a bra, which I then had to wear all the time for several weeks. Finally, after 8 very long days in hospital, during which I'd barely left the room that my bed was in, my 4 drains were removed, which was a massive relief as they were really heavy and inconvenient, and I was discharged. After I was discharged from hospital, I went to stay with my parents for a few weeks. Usually I live alone, and it was not feasible that I would be able to do that immediately after being discharged from hospital following such major surgery. I still had massive bandages on both of my breasts and abdomen, which needed to be changed every second day. And I also still had a lot of fluid building up inside of me, which had to be periodically drained in hospital. In fact, this buildup of fluid became so bad that at times it looked like I was pregnant. I was also still very tired most of the time, which was frustrating, especially when other well-meaning people who wanted to visit didn't really understand that I was simply too exhausted to see them. I was also unable to drive or exercise in my usual way, which was annoying. Having said all that, I have never been so pleased to get back to my parents' house. At the time, my sister commented, "I knew you must still have been quite unwell because you were so pleased to be back at Mum and Dad's." My reply was something like, "You have no idea how hard it is to be in hospital, unable to do virtually anything, including having a shower, and with 4 heavy drains coming out of you for 8 days. As time progressed, I slowly began to heal and get better, although I did attend a civil service job interview with bandages still on my breasts. Finally, having had the operation in March, I was well enough to begin a new job at the Department for Transport in July 2017. As already mentioned, the surgeons had some problems with my left breast during surgery. As a result, the outcome was that things looked a bit messy once I'd recovered. So I underwent a further operation in November 2017 to try to tidy things up. Following that, I had several rounds over several months of micropigmentation or tattooing to create a semi-permanent image of nipples on my breasts to make them look as realistic as possible. The overall result is far from perfect. My left breast in particular still looks a bit odd, especially when compared to my right, and the tattooing, which was never great, is now somewhat faded. But to be honest, it doesn't bother me as much as I know that it bothers many other people, so I guess I'm quite lucky. The thing that I still find really peculiar is that I have no sensation at all in either of my breasts, which I've never really got used to. For me, the decision to have a preventative hysterectomy and my ovaries removed was more difficult than the one to have a bilateral mastectomy and reconstruction. When I was diagnosed as having a BRCA2 gene mutation, I was a youngish woman in her 30s who was single and did not have children. And obviously, without a womb and ovaries, it would be impossible for me to carry biological children in the future. I therefore did not make an immediate decision about it. Then, in October 2020, when I went for a routine scan of my ovaries, which were periodically undertaken because of my high risk of ovarian cancer, I discovered that I had several fibroids that were so large that the nurse was unable to see my ovaries on the scan as the fibroids were obscuring them. This led to my consulting with a leading professor of gynecology about my best course of action, given the size and number of fibroids I had and my BRCA status. And as a result, I decided to have a hysterectomy and oophorectomy. I knew that the consequences of my decision would mean that I wouldn't be able to carry biological children in the future. But as I had previously been advised not to have children as a result of a separate and misdiagnosed medical condition, I guess it made it less of an issue. To be honest, I think it was more upsetting for my parents, other family members and friends. As I said earlier, I feel like I've been through much worse. My gynecologist was keen to undertake my operation using keyhole surgery, and therefore I agreed to undertake several months of hormonal injections prior to the operation in order to try to shrink my very large fibroids in an attempt to make this feasible. All of this was ongoing throughout the pandemic and associated lockdowns, which presented multiple additional problems, including a delay to the original scan, which first identified my fibroids, an unexpected and last-minute delay to my initially seeing my gynecologist because he had to go abroad for his father's funeral and then had to isolate upon his return to the UK as per the rules at the time, my having to attend all appointments as well as hospital for my operation alone with no visitors allowed, and my having to isolate both before admission to and immediately after discharge from hospital. In addition, sadly, in February 2021, my maternal grandmother died from esophageal cancer, which as things currently stand, is not known to be of increased risk to people who are BRCA carriers. About a year before my grandma died, she was tested to ascertain whether she had a BRCA2 gene mutation. And unsurprisingly to any of us, including her, she did. We think she inherited it from her father, who was discovered to have had pancreatic cancer via a post-mortem after he died in 1978. More than a year ago now, in June 2021, I finally had my hysterectomy and oophorectomy. Even after shrinking, my gynecologist said that the size of my largest fibroids were the same as a 12-week fetus, which gives you an idea of the magnitude of fibroids that I was dealing with. I again stayed at my parents' for a couple of weeks following discharge from hospital. Whilst a hysterectomy and oophorectomy does constitute major surgery, I was fortunate that it was done by keyhole, and therefore my ability to return to something resembling normal life was much quicker than when I had my double mastectomy and reconstruction. One of the obvious side effects of having a hysterectomy and oophorectomy when you are premenopausal is that it puts you immediately into a surgical menopause. This means that I've had to begin HRT under the guidance of my GP, who I think is actually on this call. This was not as easy as it sounds during a time when obtaining GP appointments was harder than ever. And to make matters worse, the HRT I am on is the one which is currently in short supply in the UK. The main purpose of HRT is to protect me from getting brittle bones and to minimise any menopausal symptoms, which so far, thankfully, haven't been that bad. I am also worried that as a result of the abrupt changes in my hormonal balance, which have been brought about by my premenopausal hysterectomy, I have a 78% increased risk of obesity and a 5 times increased risk of severe obesity. I also need to have annual bone density scans, annual skin checks because of my increased risk of melanoma. My maternal uncle, who does not have the gene mutation, has previously had skin cancer. And once I am 55, regular pancreatic screening. I have what I can only assume is permanent scarring as a result of my preventative surgeries, which is quite depressing to see on my body every day. But I guess over time I have got used to it and it no longer bothers me that much. It was nevertheless still reassuring that someone who I was talking to at my sister's birthday party earlier this year commented to me that I had done the right thing by undergoing my preventative surgeries, as she has a friend who is not much older than me, has children, is also a BRCA carrier, hasn't undergone any preventive surgery, and sadly now has stage 4 ovarian cancer. And now handing back to Katrina.
Okay, thank you so much, Sara, for sharing that very personal and valuable insight into your experience of living with a BRCA mutation. You can help answer this, but from what I understand from your story, that although you've had far from an easy journey, it seems that on balance you are sort of grateful to have the knowledge that you are, that you found out that you were a BRCA carrier, and have the opportunity that gave you to manage your increased risk for cancer. Would you say that's fair to say?
Yeah, I would.
Okay. I think it's also important to note that not all BRCA carriers go down the route of risk reducing surgery, that it is definitely a very good option in terms of reducing risk, but it's one of various options that are available to help manage BRCA associated cancer risk. And other options include increased surveillance, which is what Sara started off initially doing. There are cancer prevention drugs, and some people opt for lifestyle changes to try and manage their risk. So the route that a BRCA carrier takes to manage their increased risk is very much a personal choice that can be influenced by many factors: the age of the BRCA carrier, the personal and family history of cancer of the carrier, where they are in their life and their family stage, their individual circumstances. And when an individual is finds out they're a BRCA carrier, they have an opportunity to discuss with genetic counsellors and other clinicians what those options are, and are helped to explore the different options to find which route, to help them to decide which route will be best for them. So if we just look for a second to say, how is it possible now for us within the increased risk Jewish community to find out if we are a BRCA carrier? At this moment in time, BRCA testing is available on the NHS, but the accessibility to that service is restricted. The eligibility is based on a family history model, and research is actually shown by research done by Professor R.manchanda, who's with us on this call, that around 50% of Jewish BRCA carriers would not be considered eligible currently on the NHS BRCA testing eligibility criteria, so would be missed because they wouldn't have the opportunity for testing. And other research that he carried out found out that only around 10% of BRCA carriers in the Jewish population have actually been tested, so that there are something like 90% of the BRCA carriers in the Jewish population are unaware that they've got this increased risk, and therefore unable to properly explore options for managing that risk. The news that was announced. Sorry?
Can I just pop in? Just say, I know a couple of people have been trying to send messages. Just make sure if you're trying to send to everyone, send to everyone. If you want to send something to Katrina, you pick her. If you pick Hereditary United, they come through to me.
Okay. All right. At the moment, I can't see any of the messages, but I'm sure when the slides go down after this next couple of slides, then I'll be able to see them. So the announcement that was made a few weeks ago by the NHS was that there is going to be a new programme based on the findings of Professor Manchanda and the sort of the almost not fit for purpose at the moment access to BRCA testing. There is going to be a new population-based BRCA testing programme for the Jewish population run by NHS England. And this is a pilot programme that will be offering BRCA testing to all Jewish adults, anyone over 18 years old, irrespective of their family history. So they don't need to show any strong family history in order to be able to access this BRCA testing. It's still in the process of development, but it looks likely that the service will be launched in early 2023. And there will be a community engagement campaign where more information will be available about when that service will start and how it can be accessed going forward. However, if from this conversation or from other conversations you have a concern about BRCA, personal or within your family now, it is possible to go and talk to your GP now and discuss with them whether you can be referred to the currently restricted programme if you are eligible. And that's for the rest of this year. And hopefully in the new year, the eligibility will be broadened so that anyone who is interested in getting BRCA tested from the Jewish community will be able to access that test. Can I just go to the next and final slide? So just extrapolating from the carrier frequency in the community, research has shown that within the Ashkenazi Jewish population, Ashkenazi Jews have over 2 times the proportion of BRCA-related breast and ovarian cancer cases relative to the general population. So in total, 40% of ovarian cancer cases in the Jewish population are thought to be BRCA-related, and 10% of breast cancer cases in the Jewish population are thought to be BRCA-related. And most of these cancers have the potential to be prevented if we know in advance that individuals have this increased risk and therefore are able to explore opportunities to reduce and manage this risk. As with the route that you take, should you find out that you're a BRCA carrier, about how you want to manage the risk, the decision to have testing is very much a personal choice. However, we are now being presented as a community with an opportunity that we haven't had in the past. For those that want to be tested, come the new year, this is going to be something that will be available and is a significant shift in the opportunity that we have as a community to prevent and certainly better manage prevention. So hopefully we'll continue to follow details as they emerge. And now I'm not sure how much time we've got left, but myself and Sara are happy to take questions. And I'd like to think that Professor Manchanda and Michelle will also pipe up if there are medical related questions, that they will be more in a better position to respond than Sara and myself. Oh. So are there any questions on the chat or?
Thank you. We're now going to open up the session to questions and comments, so please indicate if you wish to be unmuted. I'm first going to call on Lisa Still, Chief Executive of High Cancer Care, to let you know about the services that they're able to offer.
Thank you. Thank you very much for inviting me to speak for a few minutes, and thank you, Katrina and Sara, for telling your story, your very personal story. So just to tell you a little bit about what High does in terms of BRCA. So the decision, I think, from what you've heard before from Katrina and Sara, is the decision of whether to test for the BRCA gene is very individual and a complex one. And it affects not only the person testing, but also their close family members. And at High, we offer a safe place where people can discuss the concerns in complete confidence with one of our counselling team, who have received additional training from the Royal Marsden and Northwick Park genetic team. And this can be provided over the phone, on Zoom, nationally and internationally. So we understand the impact of discovering that you're a BRCA carrier can have on a person's emotional and mental well-being. In addition to counselling for individuals and couples, we offer specialised support groups for BRCA carriers. People can join at any time of their BRCA journey and talk freely about their emotions, their fears, the dilemmas, and issues such as the impact it's having on their marriage, of whether to tell their children, siblings, and parents. And sometimes various members of a single family faced with the same risk may make different decisions. So as Katrina said before, I think that men can also carry the BRCA gene. And so we run a mixed group and a group for women only. And we find that people really have a great experience in the groups, allow everyone to explore their feelings, share advice and information. And knowing that you're not alone is so important. I know, Sara, you said that you felt people didn't really understand what you were going through. And I think
some did and some didn't.
Yes, yeah, I'm sure it wasn't everybody, but I think it's hard for people to understand what you're going through.
I was really lucky because a friend of mine introduced me to another friend of mine who I think is on this call, who had been through effectively the same thing as me, with the same surgeon in the same hospital for the same reason 6 months before. So I was quite lucky.
And I think that's the purpose of a group, is the experience to share information, to share feelings, and knowing that you're not alone. And there's a lot to be said for the commonalities that are shared. So I just want to say a little bit about what HI do, and is there for anyone if they want to discuss the implications of going for testing, of having the gene, that we're there for the community.
Thank you very much. Let me see that there are a few things in the chat. Let me go to them. Helen Cook asks, how can we access this counselling, please? Who can take that one?
Which counselling are you referring to? For people?
Could Helen Cook unmute herself? Well, maybe. Well,
if she's talking about the genetic counselling, certainly when I was tested, the only way she's put post-BRCA diagnosis in the chat, so she's answered that. I don't know the answer to that.
Okay, so just I mean, Ranjit, feel free to jump in, but the standard model of delivering BRCA testing on the NHS at the moment is that there would be a session of pre-test information revision to enable people to discuss and understand what it means to be a carrier, what the implications are, and have an opportunity to decide, actually, is that something that they want to go forward with or not, once they have the implications, and also understanding what the test involves, which was one of the other questions in the chat. Then following the results, there is generally a second session with a genetic counsellor that will go through the results with them and sort of consolidate information about what this means and what options there are available for them going forward to manage their risk, also how they can possibly work with sort of communicating their result to other family members. And that's the sort of standard model within the NHS, which is going to be largely replicated in the new programme in the new year. But should they decide then that they want to go down, whether it be risk reducing surgery or something else, they would be referred on to the different specialist areas or support that would help them on that journey. And then, as Lisa mentioned, there are lots of other, in addition to the NHS sort of standard system, there are lots of other support agencies in the Jewish community with high cancer care, but also nationally BRCA groups where people can share their experience or ask questions in forums. So that's something that we're hoping as a community as well to coordinate into a centralised place so people can access that more easily.
I should add, my experience of the NHS genetic counselling is the same as Helen's. It was poor. It was poor and fairly useless, and so it's good that there's all these other options, because that my experience, it maybe it varies, but my experience was the same.
Right. And I think that Helen wanted Lisa Steele to ask how to access counselling as well. Could you unmute yourself?
So if you phone High Cancer Care and speak to anyone in the services department, ask to be put through, then we will be able to help you.
Fine, thank you.
May I chip in?
Yes, go ahead.
I'm sorry, but thank you so much for sharing your story. And I'm sorry to hear about the poor experience with genetic counselling in the NHS. by some of you. I suppose what I would say is that hopefully, if you do face an experience where you are not satisfied with the counselor, you should be able to ask for someone else. The other thing to consider would be to get referred to the specialists who actually manage your risk. So the breast team, I would hope, would provide you good counseling, or should be able to provide you counseling around breast risk management. And a specialist gynae oncology service or a specialist gynecology service would be able to provide you counseling and support for managing your ovarian cancer risk. And if the people you see aren't satisfied, then that's not your experience, Lily.
I agree with Helen. At the time, my father pushed really hard, and it didn't happen. And I think Helen's concurring. I think people can't take themselves off mute. But I think what people get told happen and what actually happens doesn't always happen. I mean, I was quite a long time ago now, so maybe things have changed.
So we have specialist centers. I don't know where people have been, but maybe one of the things to consider is which center you go to.
Well, I wasn't given a choice. I was sent to Northwick Park. I would never have picked that hospital. I've got a bad association with that hospital, and I'd have never picked that hospital if I'd had a choice.
Can I pitch in for a second? Sorry, Ranjit. As part of the research that I'm actually doing in partnership with Professor Manchanda, we have been interviewing Jewish BRCA carriers, a representative sample across the whole community, and there is no question that there is a lot of varied experience in terms of their genetic counselling support. So that there is, I think it's fair to say, your experience was your experience, and you're not alone in that, but there have been others that have had very positive experience. And there was also quite a lot of people who said that actually they were probably given the information at the time, but because of dealing with the processing of the information, they didn't necessarily process all the information and the options, because they just sort of needed a bit more time to get over the fact that they were finding out that they were carriers. So it is varied. Some people have positive experience, some people have less. What we're hoping with the new program is to ensure that the best practice is available in terms of the BRCA, the genetic counselling provision.
So yes, I mean, I would hope that GPs would be able to refer you to another center should you not be happy with your current doctor or clinician you're seeing. We definitely get referrals from across the board from lots of centers. We would be very happy to receive referrals, but I appreciate the lack of it, the variation in care and experiences, and there's a lot that needs to be done to improve that. There is the other thing we're working on at the moment is a nice guideline on managing women at increased risk. There's one for breast cancer, but we're working on the ovarian cancer guideline. And hopefully with these things coming into place, there's going to be more awareness and more equity in care as we go forward.
Thank you.
I think Dr. Farris wanted to add something, and it's probably about this, so maybe can we unmute her so that she can?
I think the next person to unmute is Jackie Aldridge, who has been waiting for some time. Could you unmute, please? Either Jackie or...
Yes, I'm unmuted. Go ahead. Hello. I'm happy to just give you a very brief resume, because I was diagnosed, I had actually had breast cancer, and then I was discovered that I had the BRCA gene over 30 years ago, because my mother had breast cancer, her sister, her aunt, and lots of the family, and that was the BRCA one that came through her father. I did not have a mastectomy. My mother, I'll just tell you very briefly, my mum had first mastectomy, second one a bit later, and then eventually ovarian cancer. So that was the time when it was being discovered. I was told I had the gene in 1990, which is a very long time to live with that gene, but I'm, as you can see here, I'm very okay. I had breast cancer at that time in 1990 in one side. I then followed that. I didn't have a mastectomy. I had a lumpectomy and associated treatments, radiotherapy, chemotherapy, etc. I then had my ovaries removed because that was deemed a risk. And ever since then, for all those, every year I've had mammograms and continue to have them once a year. And I'm now 71 and hopefully I'm still okay. So I've been okay. I've been under Guy's Hospital and I've had very good experience with Guy's Hospital. They always did have a genetic counselling group, and we had every year, until very recently, till lockdown, they had meetings and for people with BRCA gene, and we would talk through lots of option things, whether that's still carried on, but certainly Guy's and St Thomas's were a very good model. But I have got one question, so I won't keep it, that's too long. And it's about the melanoma, which I have to say, I know that there's a risk of also having, you can, even after having the ovaries removed, there is a risk of having cancer on the lining of the stomach. That what I was told, but I didn't know anything about melanoma. So can the doctor please mention that a bit more for us, please?
Who would like to fill that one?
So I guess the risk of melanoma is very small. There is not a lot we do from a screening perspective for it, but the absolute risk is extremely small. Similarly, there's an increased risk of pancreatic cancer, for example, with BRCA2, which again is really small. Also, to answer your question on the Guy's clinic, yes, it's going very much. They have a multidisciplinary BRCA clinic. In fact, I was part of that clinic for many years. And similarly, you have multidisciplinary clinic running. We run one at Barts, and there's a good setup at UCH also. So those clinics are running. The risk of primary peritoneal cancer or cancer in the lining of the tummy that you mentioned is really small. There's no testing or screening for that, and I wouldn't worry about it. You have had the maximum risk reduction that science and technology can provide, and if at all a residual risk, it's extremely, extremely small. But I would say there is one question in the chat because I can just see it. And it says, is there a higher risk of getting ovarian cancer during pregnancy after having had a mastectomy? The answer is no. And the next question is, would hormonal changes increase the risk of getting ovarian cancer in BRCA woman carriers? And the answer again is no.
Right, thank you. Michelle Ferris.
Thank you. So first of all, I just want to say how proud I am of Sara's presentation. She and I met up sort of towards the end of her journey through this. And I'm sorry that, Sara, that you had such poor experience with Northwest Thames Cancer Genetics. That was before I was with you. And we are restricted to where we can refer unless people go privately. So yes, Northwest Thames for Edgware is it.
When I did it, you couldn't have it privately. That wasn't even an option.
Yeah. So that's the first thing. I think what we're finding, we run a program for schools. Currently, we're in 22 different schools, primarily started at North London Collegiate and then in the Jewish schools, but we do Northwest London, Northeast London, and some in Manchester previously. And we are a team of 10. We go into the schools and we talk about breast cancer per se, so how to pick it up, how to examine yourself at a young age, because in the community, breast cancer is 1.5 times as much in women pre-menopausal, which is unusual in the Jewish community, in the Ashkenazi community. We also talk about lifestyle. So if you say, if you have a BRCA gene, you might have a 50 to 80% risk of developing breast cancer in your lifetime, but there are lifestyle measures which impact on that risk. So we talk about that. And then we talk about genetics. And on the back of that, we have families coming to us in practice saying, my daughter had this experience at school. I think in our family we've got BRCA. Can we come and talk about it? And the whole family might come. And then we have to work out who's going to get tested, depending on who's the closest relative to the people with cancer. So that's very exciting. Yeah, so that's where we're at with that.
Thank you. There's a question on YouTube, I think. What screening would be done for male carriers, and when would it be advisable to start?
Is that for breast cancer or for prostate cancer? For breast cancer,
prostate cancer, I assume is in the question.
I suspect they mean for anything, like what screening should men have?
Okay, so for breast cancer, there is no screening for men. There is a small increased risk of breast cancer, particularly for BRCA2, about 6 or 7% lifetime risk. The risk in prostate cancer is mainly with the BRCA2 rather than the BRCA1, particularly the more recent data shows. And Professor Rossi has been running a study where now they'll be evaluating different types of screening strategies for men who have the BRCA mutation. So there'll be opportunity of getting screened within the research trial. There is no NHS-based screening available at the moment in this context.
Right. I mean, Calabello wants to know, should all BRCA carriers be given pancreatic screenings or only ones with a family history of pancreatic cancer?
So, unfortunately, pancreatic cancer is a cancer which is very difficult to screen for. There is no screening strategy which works for which has been shown to work for pancreatic cancer. So it's still very much a research question. There are research studies which are ongoing and have been evaluating this, like the EuroPanc study, and there are new studies which will be starting on different types of biomarkers which may be useful in pancreatic cancer. But it's not been shown to save lives, and there isn't a screening strategy which works as yet. So it's still very much a research question.
I've been told I'm supposed to get screening for it when I'm 55 upwards.
For pancreatic cancer, how? In a research setting, yes, but not outside a research setting.
Oh, okay.
Yeah. Someone else has asked, if my daughter is negative for the BRCA gene, does that definitively mean I do not have it?
No.
Not unless it came from dad.
No, because she could have inherited it from her father.
Yeah. So if you as a BRCA carrier, you have a 50% chance of passing on the mutation to a child. So that means with every child, they have a 50% chance that they are a BRCA carrier, or 50% chance of them not being a BRCA carrier, even if you are a BRCA carrier. So the fact that your daughter is not a BRCA carrier doesn't actually mean that you are not a BRCA carrier, because that's not statistically the way that the inheritance packet.
And siblings might not be the same. Like my mum and her brother, one is, one isn't. It's not. It doesn't necessarily impact the class.
And it's also a sort of a game of statistical averages to an extent. So it is on average you have a 1 in 2 chance, but the way it works is that in some families you will get some of the interviews of the BRCA carriers that I've had. You'll have 5 siblings that have all been BRCA carriers, or you may have other families where there's 1 BRCA carrier and 6 aren't. So it is statistically, it's a 1 in 2 chance of passing it on. If your child doesn't have it, it doesn't mean that you don't have it. If your child does have it, it does mean that either you or your partner will be a BRCA carrier. But does that answer the question?
Right, and someone else, presumably this is related to the current COVID situation, saying that they've been begging for therapeutic support, have been told a 9 to 12 month wait. Is that because of the problems with the health service at the moment?
Therapeutic support for what?
Well, that's all I've got.
So
has it got worse during COVID?
I think it has, without doubt. Every part of the health service has been impacted by COVID. But if you could get some information on what the issue is, we might be able to advise on how to tackle it or address it.
Right. I think we ought to put this in context. Assuming that there's roughly 280,000 Jews in this country, and most of the Ashkenazim, if it's 1 in 40, we're talking about 7,000 people possibly having this gene mutation. So it's quite a large number, isn't it?
The person, Helen Cooks, put that she was talking about therapeutic support dealing with the damage of knowing I'm BRCA positive and how to deal with decisions that need to be made. So it's basically post-diagnosis counselling, as it were.
So is it decisions to be made with respect to managing her risk?
She's put in the chat that she's just been told she's BRCA positive. Here's the surgeries, decide now. So i.e. that I agree, that's not really counselling.
So, okay, so if her GP would I don't know where she's based, but if a GP would like to refer her to see us, we have a psychologist embedded in our clinic, and we have a multidisciplinary team. We would be happy to discuss and support her through her ovary and cancer risk management.
Right.
And it will not be a 9-month wait.
Right. Could I ask Elliot to flash up on the screen the contact details for both Sarah and for Katrina, in case anyone wants to contact them?
And the professor, could you put in the chat the contact details? Because I think that Helen Cook's just written, wow, that would be amazing. Could you please send me the details? So could you
Michelle, did you want to come back? Your hand is still there.
Yes, just to say that Ranjit did a big study previously where BRCA was 2.45% of the population when we're looking at families where there was one Ashkenazi grandparent. But if there's family history, it's affecting about 10% of those people. And the problem that we have in the practice is that there are huge Holocaust families, so there's no family history. And I think that that's terribly important to take into account. Yeah. So when you're taking histories from these families, it's not okay just to say, is there any cancer in your family, and leave it at that, because if half the family has been decimated, then we don't have that information.
Right.
Yeah, so our updated data suggests about 2.9%, so almost 3% is the prevalence in the London population, and the prevalence in people who do not have a strong family history can go up to 2%. So just like Michelle said, and Michelle was one of our key collaborators and sites for our study. So she did a huge amount of work on that.
If you look at the chat, you'll see that the emails are Sara at balabanoff.co.uk and Katrina at jsc-review.uk. I'm just going to see if there's anything else. Does anyone else want to raise any matter?
Well, there's some comments earlier on in the chat that haven't been.
Yeah, there was a question about what the test involves. In terms of practical testing, it usually involves taking a blood sample, and the DNA is extracted and then processed at a lab to see whether there is mutations. But it's now possible to do the DNA extraction also from saliva and process it through that way as well. So the current NHS testing generally is a blood test. Going forward to next year, the expanded programme may be people being tested by giving a saliva sample going forward.
Having the test was not hard. It was basically a blood test in my case. It's everything associated with that, including the results, which is harder. But the actual test neither takes a long time nor is it difficult. You can kind of, do other things in the same day and so on.
Yeah. And then, sorry, Ranjit.
So no, one of the questions is, I don't know, I'm just looking at what questions have not been answered in the chat. And it's, do you think research within the next 10 years will progress to find a cure? I suppose it depends on what we mean for a cure. If it's preventing the gene to go from going to the next generation, you could do that today through pre-implantation genetic diagnosis. That technology is available. A small proportion of people opt for it, but it's available on the NHS. There will be better preventative options, I sincerely hope, in the next 10 years. And I hope we will have better biomarkers and things to screen for ovarian cancer and things that we don't at the moment. But so prevention, chemo prevention and surgical prevention in particular is very, very effective in preventing.
But there's also a trend to more personalized medicine, that people that have been affected by cancer are sometimes now being tested whether the BRCA mutations, because knowing that they're a BRCA carrier can influence the type of treatment and the effectiveness of the treatment that is prescribed for them. So it's the knowledge of BRCA status actually can help with treatment in addition to the options for prevention.
Yes, you're right. So you can be eligible for what's called PARP inhibitors, which has clearly been shown to improve at least progression-free survival. In particular, I would say it's revolutionized ovarian cancer treatment.
Right. Dr. Ellis Friedman has said in the chat, women with BRCA gene are also more likely to have early breast cancer, that is under 45 years.
That's correct.
So that's quite important. I think this has been a very useful session. Could I ask whoever could answer this, how do we get our message across to the general Jewish population? I mean, we had a very fine attendance here tonight, but we need to get the message out to people within the whole of the community. How do we disseminate the message?
Well, we hope there'll be an engagement. Well, there will be an engagement campaign, and we will be generating materials and information to be able to disseminate, and we would count on people like yourselves and lots of the people who are attending at the moment and other stakeholders to make a huge effort to support this endeavor.
Right.
And that will be a collaborative effort with HI being involved and other stakeholder organisations of the community, so that the effort will be made to really reach across the entire community so that they're well informed and can make the decision whether this is something that is something they want to know themselves.
Someone has just wondering if one uses an ancestral genetic test, which is usually just the recreational type test, would BRCA show up too?
Not those aren't, in my view, that reliable. I would go for a proper test.
Yes, they're not. Most of the hereditary tests are not accepted by the NHS. The results, they would need to be tested again. There are, for those who are currently unable to access, when I say currently, this year until the wider provision of BRCA testing for the Jewish community, there are private options if they're not able to access NHS testing. But there are many cases where they're not provided with effective genetic counselling. So if someone was looking to go down that route because they can't access genetic testing in the next few months, then they can contact me and I can help sort of guide them to which private providers actually have a professional and responsible service.
Right.
There's a question in the chat about INVITI. So INVITI is a reliable provider.
Yeah.
I wouldn't think you would need to repeat the test if it's an INVITI test, and it's very likely that whoever you see will accept that test result and not ask you to repeat it. Right. There are some INVITI, color, EGL. There's some reliable providers.
Yeah.
Patricia Spatula says, I've done the genetic test with INVITI from San Francisco, which came back positive for BRCA1. How accurate do you believe these genetic tests are? Do you recommend to have another test done before actually having the prophylactic mastectomy?
No, INVITI is reliable. You don't need, I wouldn't need to repeat an INVITI test. That's a reliable provider.
Right. I'll take just one or two more points before we come to a close. Does anyone else want to find a word?
I think there are some general comments in the chat which aren't necessarily questions, but they're comments. So I think afterwards, all the comments, everything that was in the chat will be forwarded to Katrina and I, so we will have a chance to read them all.
We'll ask our controller, Elliot, to do that.
Could you just give information about this session being recorded? So if people know of others that were interested in coming tonight but weren't able, where they can access this session?
Yes, I'll do that now that we're closing. So I'd like to thank everyone who participated, and particularly Sara Balabanoff and Katrina Sarig for their presentation this evening. I think this has been a most informative evening, and I hope that people will now have a better idea of what facilities are available if they're at all concerned about the possibility that they may have inherited the BRCA gene mutation. This session will be uploaded immediately to the HWA US YouTube channel, where you can also find many of our past recorded sessions, and it's going to be passed to the United Synagogue, and it could very well be put on US TV or in the weekly newsletter. So we'll try as much as we can to disseminate what has happened tonight. But if you're in any other organization, if you want the link for this one, please let me know, or copy it from YouTube and pass it on to your synagogue or organization. Thank you very much.
I'm speaking slightly out of turn here, but I dare say if you got in touch with Katrina and I, we might be persuaded to repeat it. Speaking for myself, not for Katrina.
No, you can. I would just say that as Professor Manchanda mentioned, that hopefully that there will be in the coming months, hopefully a much more information coming through to the community, across the community, about BRCA in general. But I can always listen to Sara speak, because of having the personal story makes it much more real and
Katrina
relatable.
and Dr. Ferris are like my biggest cheerleaders.
Let's just conclude with each of you giving your email address again, in case anyone wants to contact you. So can you just give it verbally rather than in the chat? So, Sara?
Sorry, I missed what you were saying. I was reading
Your email address.
Each of you give your email address again.
You want me to say it verbally? It's my first name, Sara, without an H, .Balabanoff, which is my surname. Sorry, not dot, at balabanoff.co.uk. So it's basically my first name, dot my surname, at my surname.co.uk.
And Katrina?
So it's Katrina, which is Katrina at jhc-review.uk.
And if you want to contact Hi, would Lisa like to give a contact for?
Sure.
Right.
It's Lisa, LISA, for sugar, at highcancercare.org.
Right. Thank you very much.
And maybe we could put our contact details also where you put it up on YouTube. Yes. I don't know, just in case.
We'll put it up in the text when we put the YouTube on.
Thank you very much, Natalie Cohen, for the compliment.
Lovely. Yeah. Thank you so much for this opportunity.
Thank you for all attending.